Thank you very much, Dr. Sabella. So 3 housekeeping things before we start. I'm going to try not to read to you. I can't stand coming to a lecture and having somebody read to me, but there's a lot of things in these 2 talks that are just lists of things, and especially with the advent of DSM-5, there's a few of the diagnoses that show up in there that we're going to talk about, and unfortunately they're very listy. I will tell a quick joke in between each section. I was once told by somebody that they'd rather eat glass than do developmental pediatrics. So to try to keep you awake, if you can't stand awake during the material, at least hang on for the jokes. And I probably will finish this first talk 5 to 10 minutes early. I'd like to steal that though if I could and have that back for the second talk if that's okay. So we'll try to have you, we'll let you know when to get back in. By the end of this talk, you should be able to list the key developmental milestones for children, state the key elements for developmental surveillance for young children, and list tools used to assess specific areas of development. So this slide's important. It points out the growth of the various types of tissues in the body. What you mainly see is that brain growth is largely done by the time a child's even 3 or 4 years of age, and myelination is largely done by the time a child's 3 or 4 years of age. So the importance for all of us is that if you can identify delays and developmental issues in kiddos early, then there's a lot more time to remediate those things. General somatic growth is the more sigmoid curve that we're used to seeing. Reproductive tissue doesn't really start to grow much until puberty. And then lymphoidal tissue I find interesting because if you see a lot of children in a primary care clinic, if you look at a child at birth up to about 2 years of age, there's really not a lot of tonsillar tissue. And then somewhere between 4 to 8 to maybe 10 or 12, there's a lot of tonsillar tissue. It may not be abnormal. And then if you look at 16-year-olds and older, they often look like they've been tonsillectomized. It all just kind of goes away. So it does fit this curve. It's important that you also be familiar with other growth inhibiting conditions such as hypothyroidism, Turner's growth hormone, etc. There are other curves that show the growth patterns for those children in the chapters in the book related to development. And there's also curves on those in the genetics chapter and the endocrine chapter. So on the exam, they often will list growth numbers for children. It's important to know that the normal head circumference for a child is typically 35 centimeters at term, and the child's head typically grows 12 centimeters over the first year of life, so they are about 47 centimeters at a year. The typical progression is that their head size grows about 2 centimeters a month for the first 3 months, and then 1 centimeter a month, months 4 through 6, and then about 0.5 centimeter a month after that. And if you see a child with macrocephaly, so familial macrocephaly, you'll generally recognize that in about the first 6 months of age. Typically, those children don't have any other worrisome signs, and if you measure the parents' heads, one or the other parent will typically also have a large head. And then hydrocephaly typically develops early, but can develop at any age. And it's generally going to happen in the first year, but you're also typically going to see things like irritability, vomiting, splitting of the sutures, other neuroabnormalities, and things like that. As far as birth goes, birth weight typically doubles by 5 months, triples by a year, and quadruples by 2 years. And a typical newborn weighs between 3 and 3.5 kilos and is 50 centimeters long. And most full-term infants will get their birth weight back by 2 weeks, and length at birth typically doubles by 4 years of age. In general, the questions on the exam are going to cover children under 3 years of age, and they're also probably more typically going to cover kids under a year of age. The reason for that is because those are the ages where the development of milestones, the attainment of milestones are most predictive and most discriminating. You can give a developmental skill and say that's typical of a 7-month-old, but not so much of a 6 or 8-month-old, etc. Gross motor milestones are probably the most predictive and easy to use in questions. And then again, the questions are sometimes accompanied by data on weight, height, head circumference, and the answers to questions are commonly given in consecutive months. Remember that I am the messenger, not the writer. Don't shoot me. Why do they use 1-month intervals? There's a concept called a motor quotient. So if you determine the level of motor functioning of a child in months, so let's say a child is now stooping to recover. We're going to come back to that. That's about a 15-month skill, and they're 24 months old. Then you put their motor age, 15, over chronologic age, 24, and that's your motor quotient. And then if the number is below 50%, that child absolutely requires evaluation. If the percentage is about 50 to 70, it's borderline, I would still evaluate a child like that. But again, important because the sooner you identify these children with delays, the faster you can remediate them. Easy way to remember the gross motor milestones in the first year of life. 3-month-old can support themselves out on outstretched arms if you place them in prone. So that's 3 months, just kind of think 3, 6, 9, 12. A 6-month-old is generally able to sit with trunk support only, with no hands. A 9-month-old can creep. Creeping is what most of us think of as crawling. So creeping is getting up on all fours, hands and knees. Crawling is actually commando crawling, where your hips are still in contact with the surface that you're on. And then a 12-month-old generally is able to walk. This also points out another general concept with development, which is that it occurs in a cephalocaudal progression. It goes from head to toe, and development also typically progresses from close to the body muscle groups to further away, proximal to distal muscle groups. Going through milestones, a 1-month-old is generally able to lift their head up and turn it when they're placed in a prone position, whereas a 2-month-old can get their head and chest up off of a surface when placed in prone. A 3-month-old can puppy prop, so again, get on outstretched arms. Important if you're doing things like taking their pictures when they're cute and little like that. Their chest should be able to completely come up off the mat, and if you have them lying supine, you hold them by the hands and you pull them forward, their head will stay back until really they're almost in a fully seated position, so they'll have pretty much full head leg at 3 months. A 4-month-old, on the other hand, will have steady head control when you place them in a seated position. If you put them and try to get them to stand, they'll generally try to stand up on their legs, and they will typically not have head lag. They'll keep themselves planar. They'll hold their head stable. And a 5-month-old will roll supine to prone, and they lead with their head. So when you go to do a pull to sit maneuver, they'll actually pull their head forward and kind of tuck it in as you go to set them up. 6-month-olds can tripod sit, meaning that if you put them in a seated position, you bring their legs out at 90-degree angles and put their hands down in front of them between their knees. They can typically support themselves in tripod. They're able to roll over in both directions. 7-monthers can sit without support and can commando crawl, so arm over arm, hips typically in contact with the surface that they're on. An 8-month-old can usually get themselves to sitting and can reach from quadruped, so if you put them on hands and knees, they'll reach out and touch something. A 9-month-old creeps, again crawling on hands and knees, and a 10-month-old cruises, walks along surfaces. If you put them, say, on the couch or some other piece of furniture, and if you hold their hands, typically they can walk. 11s are able to generally stand without support, and 12-month-olds typically start to take independent steps and stand on their own. A 15-month-old should be able to walk well. If you have them standing and you put something on the floor that they want, they'll be able to stoop to the floor and pick it up. They recover that. And they can usually run stiffly at 15 months. An 18-month-old will run a little better, still awkwardly. If you have a large object, such as like a shopping cart, toy shopping cart or something like that, they can push that along. And these are all ABP standards. You probably have everybody here probably has their own kids. Lots of you have your own kids, and you'll think, well, my child did that at 12 months. These are the ABP guidelines. They can throw a ball from a standing position, and they can walk upstairs if you hold one hand. We'll come back to that. 24-month-olds typically can run pretty well. They can actually kick a ball, jump in place, and throw a ball overhand. And then 3-year-olds, this one's nice. Think of 3-year-olds can ride tricycles, so 3 years, 3 wheels, and they can also balance on 1 foot for 3 seconds, so 3 and 3. 4-year-olds hop on 1 foot 5 times in a row and can balance on 1 foot for 8 seconds. 5s can hop in place 15 times, balance on a foot for 10 seconds, and skip. They also can dress and undress themselves. And 6-year-olds ride a bike without training wheels, hop on 1 foot for 15 feet, and do a running broad jump of 2 to 3 feet. Stair climbing abilities. So a 15-month-old can typically crawl upstairs, which you probably have seen that. And then an 18-month-old, if you hold one of their hands, they can usually go up the stairs. They're typically going to bring both feet onto the same step going up. A 2-year-old can ascend and descend by placing both feet on each step. So again, every step they take, both feet are going to come to it, and then they'll hold on to the handrail. A 3-year-old can typically alternate their feet going up the steps and then bring both feet to the same step coming back down. And a 5-year-old can alternate feet on each step going both up and down. And they may give you that may be part of one of the questions, and it's a nice little distinguishing skill to know. Also helpful if you're working in a clinic. Red flags: if a child rolls over before 3 months, I'm not thinking of the child who does it once or twice, because when you see a child, say for a 4-month exam, and you say, has your child rolled over? Yeah, they rolled over once a couple weeks ago. I don't really worry about that at all. If a child is consistently rolling over, my worry is that they have some degree of spasticity. And if you're familiar with the asymmetric tonic neck response, remember if you take a 1-month-old and you turn their head fairly quickly to the side, the arm that they're facing towards should go out in extension, the leg should come up in flexion, and the other arm comes over. They call it the fencer's position. So because of that, that child should not be able to roll over, and it's one of the protective reflexes, and that's why kids have it. So if they can roll over before 3 months of age, number one, they've probably lost a protective response sooner than what they should have, and they probably have some degree of spasticity that's pulling them over. So that's a worrisome sign. If you place a child in sitting and they have poor head control at 4 months, also a red flag. Not sitting or rolling by 9 months. Persistence of the Morrow response, the startle response. If you clap your hands or bump the crib that they're in and they don't startle, if they do startle still at 9 months, that's a concern, or past 6 months. The tonic labyrinthine response is if you have their heads back, if you place the child's heads back while lying supine, the back will stiffen, their legs extend and adduct, so they scissor. Their feet plantar flex. Think of all the things you see in cerebral palsy. Their elbows and wrists flex and their hands fist. So again, a lot of the things that we see in cerebral palsy, that'll happen with them. Let's see, and then if they have a lack of protective supportive responses at appropriate ages, so you place the child in sitting, a 6 or 7 month old, if you have them in a seated position and you push them from behind, they'll at least stiffen their back. They may not completely protect themselves, they may fall over, but they'll try to stiffen their back. If you go side to side by 7 to 8 months, again, they'll typically put a hand out to keep themselves from falling over. And then somewhere around 9 to 10 months, if you push them from the front and try to knock them over, they'll stiffen again and they'll maintain their position. If they don't have those, that's concerning. If they're not bearing weight on their legs by 12 months, and if they're not walking independently by 18 months, that's again a concern. What do you call a row of rabbits hopping backwards? A receding hairline. Fine motor milestones: 3-monthers generally are unfisted. Hands are unfisted most of the time. If a child has what are called cortical thumbs, where the thumb is underneath the fingers on that hand, that's abnormal likely if it's present after 3 months, and absolutely if it's present after 4 months. It's a sign of an upper motor neuron lesion, and that's a child I would watch very carefully later on for the development of cerebral palsy. 6-monthers can transfer an object from hand to hand, so they have something in one hand, they pass it to the other hand at 6 months. It doesn't count if they have it in that hand, put it in their mouth, take it out of their mouth, and get it to the other hand. It has to go hand to hand. 9-monthers have an inferior pincer grasp. The thumb meets the index finger on the side when they go to pick up, say, a Cheerio or a pellet. A 12-monther, it's thumb tip to fingertip, mature pincer grasp. And then a 15-month-old should be able to both scribble with a crayon and hold a cup, and an 18-month-old should be able to hold or feed themselves with a spoon. Okay, tower building skills. This is one I'm not going to read to you, but understand that they love to put these on the exam. So this would be a good one to make a file card out of. Drawing abilities, these have changed a little bit, and it's always funny to me that they make some of the developmental milestones change. Some things make sense, like the age that kids roll over actually changed when the Back to Sleep campaign came into being. I'm not really sure why this one changed, but these are a little different. So a 15-monther, if you hand them a crayon, they'll scribble. If you give it to an 18-monther and you imitate a single vertical stroke, they'll imitate a single vertical stroke. A 24-monther will imitate a circle, probably won't do a really good one, but they'll imitate and they'll do horizontal lines. A 36-monther can draw a single circle. So the 24-month does circles and the 3-year-old does a single circle. A 4-year-old can copy, if you've done it, a cross and a square, a 5-year-old a triangle, and a 6-year-old a diamond. If you're familiar with the Giselle figures, they're in Harriet Lane, and you probably have seen them in something. We still use them every single day in the office, but the numbers that they use are slightly different. And there's some variance with the development of fine motor skills, so if you do use those, I still find them helpful in the office. I wouldn't stop using them. But for the purposes of the exam, this is what you need to know. Typically, if you have fine motor delays, they're coupled with global or gross motor delays. I would always think about really checking that child's vision, especially look for things like binocular vision, strabismus. If they can't see well, they're not typically going to have good fine motor skills. Fine motor skills are also important later in life for the achievement of self-care skills, independence, and academic achievement. So very important. And what is a vampire's favorite fruit? Nectarines. Okay, receptive language milestones. 4-monthers, if you're talking, they'll turn their eyes and they'll look towards where you are when you're talking, whereas a 6-month-old will actually physically turn their head to look to you. They'll turn their head to look towards a voice. A 9-month-old will orient to their name. 12-monthers can follow a one-step command with a gesture. 14s can do the same without a gesture. 15-month-olds can point to a body part and follow a simple 2-step command, go and get the ball and bring it to me, get your shoes and bring it to me. 18-monthers typically can point to 3 body parts, and if you ask them, where are you, and name them, they'll typically, point to themselves. And then a 24-month-old can follow a 2-step command, and they understand simple prepositions like me and you. Kids are actually really fascinating in the early stages, before we really have discernible milestones. Kids know their own language better than other languages. So they've done studies where a baby will be nursing on a bottle and somebody will start speaking a different language. Since that's novel to them, they'll actually slow down and pay attention because they're not familiar with that. But there's just a whole bunch of things like that they know in those early stages that don't really lend themselves to addressing milestones. Expressive milestones. A 2-month-old will have a social smile. They'll spontaneously smile if you walk up and make your goofy mom and dad faces and talk to them. They also typically start to coo. So cooing is cooing, it might be a vowel sound. Cooing are vowel sounds and babbling are consonant sounds. So 2-month-olds make vowel sounds, 6-month-olds babble, make consonant sounds. Kids who are completely deaf will typically coo early on, but they typically don't progress on to babbling, or if they do, it comes much later. A 9-month-old will imitate speech sounds, talk kind of back to you if you say something to them, and the ABP says they say mama and dada as nonspecific sounds. My kids, I don't think, said mama and dada until they were about 18 months old, which always made me scared. 12-monthers will say mama and dada with meaning, and they'll say at least one additional specific word, and they use something called proto-imperative pointing. Let's talk about this for a second, because this comes up again and again and again. This has become a really big deal. Proto-imperative pointing is where a child wants something, but they don't have a word for it, and they don't have the ability to express to you in a sentence, I want that thing over there. So they'll point at the object. Let's say it's a cup of milk. They'll point at the object, they'll look at it, they'll look at you, and they'll direct your attention to it, typically by grunting and pointing again. And then when you get it, that they are trying to communicate this with you, then they'll stop. That's proto-imperative pointing. So think of that as the baby is saying to you, it's imperative that I have that cup of milk over there. Please go and get it for me. The next thing is proto-declarative pointing. Proto-declarative pointing is where, let's say, an airplane flies by overhead or a dog runs by the window, and they want you to share in their enjoyment of that thing that just happened. So they point also at that thing and they direct your attention to it to say, that was really neat. Did you see that happen? So think of that as them saying, I do declare. That was really neat. Please share in my joy of that. That's proto-declarative pointing. So that declarative usually comes at 15, imperative usually comes at 12. 15-monthers usually use 3 to 5 words, and they have something called mature jargoning. They'll babble, but then in the middle of the babbling, they'll use an actual word, so that's called mature jargoning, and they'll greet people. Mom or dad walk in the room, mommy, daddy. They'll use actual names for people. 18s have 10 to 25 words, 24s, 50-plus words. And then an important point is developmental disfluency. I just saw this in the office last week. They had video of this 2.5-year-old. So developmental disfluency, think of that as not real stuttering. It looks like stuttering in a sense. The child gets caught on a sound in a word, they repeat it, everybody gets nervous because they think their child's going to go on to develop stuttering. But I think of it as just in the same way that we develop our fine motor skills. Your tongue is very much like, in a sense, a finger. It's got so many muscles in it, and they just can't figure out what to do, and it's tripping over itself. So they repeat a sound, and that's incredibly common in a 2 to 3-year-old. The distinguishing characteristics between that and stuttering usually doesn't occur until about 5 or 6 years of age, and those kids usually have just a look of discomfort on their face. They know what they want to say, and they just can't get the word out, and it's frustrating to them Developmental disfluency, there's absolutely no discomfort. They don't really seem to care. Very, very, very common. Other things, vocabulary. So a 1-year-old should have, again, 1 word. 2-year-olds should have 2-word sentences. How understandable should a child be if you make the number, the year 4, your denominator, and their age in years, your numerator? A 2-year-old should be 50%, a 3-year-old 75%, and a 4-year-old 100% understandable. I used this yesterday with a child. I had a 4-year-old in the office. I was talking to the mom, how much of his language do you think a stranger would understand? Oh, about 50%. And that's about where I was at with what he was saying to me. I was clearly not understanding at least 30 to 40% of what he was saying. And having done this now for 22 years and seeing a lot of developmentally delayed kids, I feel like I'm pretty good at that kind of stuff. So he got a referral, but that's a good way to figure out where they're at. It does not mean that a 4-year-old will have perfect speech. They may have substitution errors, they may have articulation errors, but you would know what it is that they're saying. Very helpful. Language development's more predictive of cognition and school achievement than any other milestone. Basically, most of language happens in our gray matter. We have language centers all over the brain, but most of it's more of a cognitive issue than the other skills, so it's predictive of cognition. It's also remediable when delays are found early, and especially if they're due to either lack of stimulation, exposure, or hearing impairments. So if you identify that early on, you can remediate it. Should you fail to remediate it, it'll snowball into impacting social development and behavior. And there's so much variability in the age at which kids get their language skills, I wouldn't get as worried about knowing this cold, for the purposes of the exam. Okay, red flags for speech and language. If the child's not cooing by 4 months of age, definite red flag. Every state in the country, I think, now does hearing screens at birth, but in spite of that, we've had kids that we've identified then at 4, 8, 12 months, 4 years, whenever, with a significant hearing problem that were not picked up by the initial screen. If they don't turn to sound or voice by 6 months of age, that's a concern. They don't babble by 9 months. They're not using mama dada by 18 months. Not using 2-word phrases or following a simple command by 24 months. Failing to use 3-word phrases by 3, or have unclear speech that you can't understand. Not using pronouns by 4. And if there's any regression in language or social skills at any age, that's always a concern. Basically, if there's any true regression in any skill, and again, an example, a parent might come in and they say, this 15-month-old used to say cup, said cup all the time. I haven't heard him say cup in 2 months. I don't really worry about that kind of stuff. But if there's been clear regression in developmental skills, the big thing that fires off in my brain is the child may have a metabolic disorder that's now getting worse. So start putting your brain down that pathway. Why don't kangaroo mothers like rainy days? The kids have to play inside. Social-emotional development. Again, there's a lot of detail on this in the book, and this is by far the most variable of all the developmental skills, so I wouldn't get too worked up about this one, but some real basic important ones probably to know. A 4-monther will laugh out loud. If you make faces, again, had that in the office yesterday, it's incredibly enjoyable. They typically will also stop crying once they hear their parent's voice. A 6-month-old will actually try to get you initiated in a social interaction. So if you're holding them and you're talking to them, if you stop, they'll talk. If you start talking, they'll stop talking. And then if you just stop talking, this is an interesting thing to do if you can find your next 6-month-old. Talk to them, go back, have that little conversation, stop talking, and it's almost like they get freaked out. They get real animated and start moving around like, come on, do something, entertain me here. They'll initiate that, that's fun. Again, according to the ABP, you can see early stranger anxiety. I think you can see the onset of stranger anxiety anywhere from 6 to 18 months. That's an incredibly variable skill. Separation anxiety happens because of object permanence. So the baby actually knows that when an object disappears, it's still there. You're playing with a toy, you put it behind your back, they'll crawl around you to go get it because they know that it's still there. So mom's in the room with them, mom walks around the corner, again, crying because I want my mom to come back. And they'll also start to play gesture games, peekaboo, so big, those kind of things in imitation of you. A 12-month-old will show bringing and giving behaviors. They'll go and get something and bring it to you, trying to initiate a social interaction. And a 15-month-old theoretically develops empathy. I would venture to say that my kids weren't so good at that either. And play ball with an examiner and start to engage in solitary play. 18s show shame and guilt. They have early imaginative play. You have a wooden block in your hand and you pick it up and you act like you're dialing a telephone and calling grandma, and you hand it to them, hello, hello, they'll talk to grandma. They'll also imitate you doing household tasks. 21 to 24s will imitate to please you, and then they engage in parallel play, so you put two 24-month-olds together. This one's playing with one toy, that one's playing with another toy. They're playing right next to each other, but they're pretty much ignoring each other at the age of 2. 36ers do associative play, where two of them will then play together, and then at 48 months, they typically start to play in groups. If you see delays in social emotional development, first thing I think of is neglect, more so than abuse, but always have abuse on your differential. We are seeing such a huge uptick in drug abuse in our area. We're really the epicenter of the heroin epidemic nationally. It's awful. We're literally having a couple of kids come into our practice every single month that were born to heroin abusing mothers. So they're now in foster care, and we tend to get a lot of those kids. My wife and I used to foster, and so I kind of have a name, like, we take care of a lot of foster kids. But also just mental health disorders, and I think those go so hand in hand. The women who happen to have mental health disorders are more likely to be drug abusers, and so we're seeing so many kids come in to the practice, and then that leads eventually to social emotional issues in the children. Early on, start thinking of the red flags. We'll get into this in the next talk, but autism spectrum disorder issues, and then sensory impairment, specifically vision and hearing issues. So speaking of sensory issues, what do you call a fish with no eyes? A fish. There you go. You guys have heard that one. That's good. Okay, developmental screening. The AAP wants us to do cross-sectional analysis. They don't want you to, number one thing they don't want you to do is to not do any standardized screening. They want everybody to do standardized screening, and they want it to be done across all domains of development, gross motor, fine motor, speech, etc. They want it given to the whole population because basically there's a lot of kids out there who don't have red flags. But they also are trying to identify the kiddos who do have problems. And the results must be interpreted within the context of the environment that the child's living in. So as an example, we have a child, they have 2 kids. We have a couple in our practice who speak, between them, they speak 4 languages, and they speak all 4 languages around the house. So their kids are incredibly interesting because at an early age, you would listen to them and you would think, wow, this child's horribly language delayed, until you realize, no, that 2-year-old just spoke a very complex sentence using 4 different languages. So I tease them all the time, your kids should work at the United Nations someday because they're just amazing. It's an amazing family, amazing children. The AAP came out with guidelines back in 2006, again stating that all children, many who don't have identifiable risks, should have periodic developmental screening. If you don't have a system in your office for when you do this, what they suggest is that at 9 months you look at motor development, 18 months communication, and 30 months focus on language and cognition. In that guideline, and this probably should be changed on your slide, they suggested that you do an autism screen at either 18 or 24 months. Now they want you to do an autism screen at 18 and 24 months. And the basic idea there is if you know what you're looking for, you can start to pick those kids up early at the 18-month visit, and if you missed them at the 18, you'll have a better chance of picking them up then at the 24. Those are the references for where the reasons for all that came from, if you want to look that up later. Okay, so there's 5 components to screening. They want you to elicit and attend to parents' concerns about their children's development. Even if a parent has intellectual delays or intellectual disability themselves, parents are very good at knowing when their kids are on par or behind other children. So if a parent brings up a concern, pay attention to it. It's highly likely to be real. The other thing is I put down sample questions that you might ask the parents under each of these categories. They want you to document and maintain an ongoing developmental history, so it's almost like a growth curve that you're going to document of their development. They also want you to make accurate observations of the child. So as an example of that, I'll sometimes ask a 6-monther's parent, can your child sit? They say no. And then you put the child in tripod, and lo and behold, they can sit, and the look of surprise on their face is always incredibly amusing. You need to identify the risks and also the protective factors. So like this child, from a 4-language family, if you did a screening instrument on that child and came back and told that parent your child's language delayed, they'd probably be very appropriately concerned, but then when you factor in that the child is actually speaking 4 languages, there are no worries. So there's positive and negative risks and protective factors on that. And the last thing is just they want you to maintain an accurate record so that you can go back and look at it visit to visit. There are developmental screening instruments that look at development globally. Those are these listed. Basically, since part of this is being recorded for audio, it's the ASQ, the PEDS, Parents Evaluation of Developmental Status, the Denver and the Bailey. Those are the general, the full screening instruments. There are domain-specific screens, so those that look at gross motor, like the early motor pattern profile and motor quotient profiles. And then cognition, Caputi scales, language development survey, and the Peabody. And there are disorder-specific scales, so like these are used commonly in the face of autism. Let's see. Evaluation generally aimed at identifying the specific disorder if there is one that can be found. They want you to assess milestones in multiple domains, just not the one of concern. And they're wanting us to look for either delays, dissociations, deviancy, or regression. So a delay is where the child is behind. They're just not achieving a skill at the expected age. Dissociation is where their skills are kind of all over the map. And honestly, I think that's true of just about every child, so I don't, again, get too worried about that. Deviancy is where they're attaining skills out of sequence. So the child that walks before they crawl, that's theoretically a concern. It's a big concern for physical therapists for whatever reason. That's, again, something I've never gotten too worked up about. And then again, regression, think of things like metabolic disorders. I'm always concerned about children with regression. If you do identify a child with delay, they qualify for services through the early intervention program here in the States. This is something that was originally created by the Individuals with Disabilities Education Act back in the 70s. It is essentially a way where the federal government gives about 1/6 of the operating budget for this program to each state, and it's up to each state to then come up with the money to run the rest of the program. But it's a way to help children get services if they have a proven, a suspected, or a possible developmentally delaying condition. In Ohio, it's called Help Me Grow, and that program works from the day you're born until the day you turn 3 years old. Once you turn 3 years old, they move you on to your local public preschool, and then you're typically in something called an integrated preschool program where you can continue to get therapy services, but you're in a classroom with other typically developing children. And the hope is that they will then serve as in a sense, like a developmental impetus or a model for you to help you get pushed along in your development. How do you spell Mississippi with one I? M-I-S-S-I-S-S-I-P-P-I. These are all jokes that were told to me by kids in the office, by the way. I typically ask every single child at every single checkup, tell me a joke, and some of the ones they come up with are pretty good gems. Okay, tips and tricks. So true confessions, this is my 18th year of doing this course. When I took my original certifying exam, I failed. So I was doing a genetics clinic. I was a developmental fellow at the time, doing my genetics clinic down in Mansfield. I drive home, I stop at what's now a Giant Eagle, just check with my wife, do we need anything? By the way, did the exam scores come? Yes, they did. She's a pediatrician. Did we pass? One of us did. I immediately knew who that was. She's the smartest person I've ever met in my life. And so I walked through Giant Eagle convinced that everybody knew that I'd failed my board exam and that none of them would ever want to see me as a pediatrician. When you go to take the exam, I would suggest triaging the questions. If you know a question, answer it and move on. And I'm not completely clear as to how your format is now. Of course, back in the written day, it was real easy. You could just write down the numbers, in one section or the other. But basically, if you had a little bit of time to think about that question and probably get it right, I'd put that into a category. And the things that you could have from now until eternity to think about, you would never know, I would just write those down on another spot and then take whatever method you want to do. If you want to do ABC, 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 whatever you want to do with those. Pick one good source and know it well. When I did my recert exam, I will absolutely tell you the best thing I used for the recert exam was the book from this course. That book bought me so many points on the recert, it was crazy. I'd also look at an atlas carefully and know the pictures because just like in the Durham lecture, you're going to get hit with a lot of pictures. If anything requires rote memorization, fine motor skills, things like that, any of the developmental skills really make up flashcards. If you see anything that ever says most common or top 3 causes of whatever, write that down. And I've said this for years, I'd make a list of causative genes because that's always a big issue. If you look at the ABP website, they'll break down what they want you to know. And if you go through it, and you look at it and you think, wow, that's a big hole, and my knowledge base. Partially you have to decide, do I have enough time to remediate that before the exam? And part of it you just have to say, there's not enough time. I need to move on. The night before the exam, sleep well and relax. I will spare you the story on that one, but the Indians were in the playoff, and we had a little bit of disagreement that night as to how late was appropriate to stay up and watch the Indians in the playoff. Okay, review questions. Question 1, a female child comes in for her checkup visit. You question her mother and learn that she's able to sit unsupported for a few seconds at a time, can pass an object from one hand to another, is rolling over from supine to prone and reaches for objects held out in front of her. You would also expect that she has recently begun to A, laugh when her parents play peekaboo, B, get to a stable position on her hands and knees, C, follow a command with the gesture shown, D, use a few simple consonant sounds in her speech, or E, perform all of the above. And the answer is D. All of the other things would actually be precocious development. And question 2, a male child is brought to you for his well-child check. His mother reports that he's been cruising along furniture for 2 months. Just this week took his first independent steps. He has a mature pincer grasp, is able to make marks on paper with a pencil, and says, Mama, Dada, milk, and bye. At the time of his next checkup, you would expect that he would be able to walk upstairs with one hand held, stoop and recover a dropped object, point to 5 named body parts, build a tower of 5 cubes, or use 2-word phrases. And the answer is B. Most of the skills listed in the question are 12-month skills, so stooping and recovering is a 15-month skill. Always remember, too, that there will be some variability. They're not going to make it super clean. Like in the question, not every single thing may be a 12-month skill. There may be a precocious skill that they throw in there, but you want to look for the preponderance of abilities and skills that they're doing, and then base your answer on that. Question 3, an 18-month-old child presents for his well-child check. You obtain the following history. He has been using proto-declarative and proto-imperative pointing for the past 3 months, demonstrates imaginative play, is able to feed himself with a spoon and can build a tower of 4 cubes, is able to walk upstairs with one hand held and can stoop and recover an object, and has not yet spoken his first word. You elect to administer a standardized developmental assessment instrument. An appropriate choice would be A, the Ages and Stages questionnaire, B, the MCHAT autism screen, C, ELMS early language milestone scale, D, the Denver, or E, the early motor and pattern profile. Okay, a little split on that one. Okay, and this is understandable. So on this one, you got to look at all the gross or the motor things that he's doing are largely appropriate, and you could make an argument that you always do a general screen first and then a specific screen second, but the motor skills for this child are largely appropriate for an 18-month-old child. So because his language skills are so delayed, I would actually on this one go with a specific language assessor. Okay, 4, which of the following children is in need of further standardized developmental assessment? A 5-month-old girl who is unable to transfer an object from one hand to the other, a 22-month-old boy who is using only 3-word phrases, a 14-month-old boy who is unable to feed himself finger foods, a 4-month-old girl who is unable to sit independently, and a 3-year-old girl whose expressive language is 80% understandable. Good, and that is the answer. The others would all be precocious development.